Sorry guys, that took a minute for me to get things to start connecting.
No worries. I was like, well, usually she's on top of this. Like, Zoom being weird again.
It was a little weird. Not really weird, but a little weird. Okay.
Professor?
Yeah?
I have a dental hygienist mandatory session at 8:30. Can I leave and join back after my meeting?
Of course.
Okay, thank you.
Welcome. Okay. I don't know if there's anything that I need to announce. Yeah, you can see my internet is being slow this morning. Okay, let's see here. Content. So I think on the syllabus, it says that we are supposed to do special, no, okay, so I don't know how we got behind in lab. Because we go, but we are not going to do this special census at all. We're going to move into this joints one. If you remember when you had to do the bony markings? This is going to be going in that same direction. We're going to be talking about the joints, and knowing the bony markings will help with this.
Professor, I have a quick question.
Go.
For the second case study, are the responses supposed to be like extremely short? Because some of mine were like 1 to 2 word answers, and I just want to make sure that that's okay.
Fine. If it doesn't ask you to explain, then that's fine.
Okay, thank you.
Welcome. And you might see the same thing in the third case study. Oh, this isn't where I'm supposed to be. Come on, Mary. So you can see there aren't a lot of videos here. Sometimes we have like 12 videos. We have 6. So try to pay close attention. We don't spend a lot of time on joints, but how do you move around as an individual, as a human being? It's all joints.
So Frank and I are going to discuss joints very quickly. So what is a joint or an articulation? This is where bones connect, or when bones connect with cartilage. So you can think of joints as, probably the most common joints you would think of is the shoulder joint, or even the knee joint or the hip joint. But there's many different types of joints, such as the joints that hold the bones of the skull together, or even the joints that hold your teeth inside of your jaw, or even the joints that hold your ribs to your sternum. So there's many different types of joints in the body, and what we're going to do is classify them according to the space in that joint, and also in accordance with how freely movable that joint.
Why don't we do something first? Pause for 1 second. If you have a printer or if you have an ability, pull up the worksheets. Pull up the worksheets for this lab. Before we even start right now, pull up the worksheets. Leo, you cannot call my shirt. No. Pull up the worksheets.
Doing it now.
Bear with me because I'm going to pull them up too. Now that I think about it.
So this is lab 12, right? Kinds of joints.
Right.
Okay. She did.
Pulling up the joints. Worksheets. Look, once you pulled it up, look through it really quickly here. Because when we watch these videos, some of the answers may be given to you right here. Because you are right, these worksheets can be rather long and extensive at times. But we spend easily, for lab, we easily spend an hour watching videos, if you haven't noticed that. And a lot of the answers are going to be given in videos. So today we'll think a little smarter, and we will have these in front of us during these videos. You'll have them. I can't have them both ways, but you'll have them as we watch these videos. And some of the answers may be given in the videos, and if I remember, I will try to pinpoint them out. Oh, that wasn't the right thing. I apologize. Sometimes I'm not very quick about toggling around on one. So,
You're fine, Professor. D2L could be extremely weird for all of us.
okay, good. Good. Okay, let's start this again.
So Frank and I are going to discuss joints very quickly. So what is a joint or an articulation? This is where...
Guys, I'm guessing that Frank is maybe the skeleton. I've named mine Bob. My mother thinks we need to name him Chester, but I've named mine Bob.
I want to know who that guy's name is.
I thought he gave his name at some point.
I
Where
don't
does he
know.
live? All that stuff.
He's pretty cute. He sounds British. Sign me up.
I'm not the only one who thinks he's kind of cute.
In that accent.
Yeah,
Yes.
right.
Yes. This is going to be a fun lab.
Bones connect with cartilage. So you can think of joints as, probably the most common joints you would think of is the shoulder joint, or even the knee joint or the hip joint. But there's many different types of joints, such as the joints that hold the bones of the skull together, or even the joints that hold your teeth inside of your jaw, or even the joints that hold your ribs to your sternum. So there's many different types of joints in the body, and what we're going to do is classify them according to the space in that joint, and also in accordance with how freely movable that joint is. So I'll say that again, we're going to classify joints by the size of the space at the joint, and also how freely movable that joint is. So let's define a couple of terms which we need to use. First term you need to be aware of is something that's called synarthrotic.
You guys, that is one of the terms in the worksheet. Find it really quickly. It's not school philanthropic. Look, it's synarthrotic or synarthrosis. I can't remember what page it's on, but it's on there.
It's on the first page, activity 3. Synarthrosis.
Yes.
Right. A synarthrotic joint is an immobile joint, a joint that cannot move.
Okay, you guys got that? Immobile joint, so a joint that cannot move.
There's also something called an amphitherotic joint.
Amphitherotic, so AMPH therotic. It's probably right underneath that one or right around it.
And
So AMPH ATHATIC.
an amphitherotic joint is a joint that can partially move.
So partially movable.
So it has a little bit of leeway. And then the last type of joint is what's called a diarthrotic joint.
DIARTHOTIC, I think. Leo, don't you dare. No.
And a diarthrotic joint is a freely movable joint. Okay. So what we need to do is, at the end of our table that we're going to draw up, classifying joints, we're going to state whether these particular joints that we outlined are synarthrotic, immobile, diarthrotic, which is freely mobile, or amphiarthrotic, which is partly mobile. Okay, so
So isn't it on that same sheet, is it where, does it ask you to define it and then give an example? Courtney?
Yes, it says classified based on their function, define the follow. Okay, well, it just says define the joints, and then it says example right under it.
Okay, so he's gonna go through the joints and we're gonna classify whether or not they're one of these three.
first thing we need to do is that there are three major types of joints that we can draw up. First type is something that we call a fibrous joint.
So fibrous joints, I think is that also on there somewhere?
Yeah, it's right under the ones that we just did.
Yeah, diarthrosis.
Okay,
Second type is what we call a cartilaginous joint. And the last type is what we call synovial joint. So these are the three major types of joints.
so it's not a no buildup joint, but it's a synovial joint. I have to make fun of some of the closed captions because they do their best. So fibrous, cartilaginous, and synovial.
Fibrous, cartilaginous, and synovial. Let's first define fibrous joints. So fibrous joints are joints in which there is no joint cavity. So what's a joint cavity? A joint cavity
So fibrous joints, there's no joint cavity.
is when you think of those synovial joints. So the joints at the knee, for example, or the hip, or doing a humeral joint here. That is when you have two bones articulating and there's a little cavity which has fluid inside. Fibrous joints do not have that joint cavity. So we can write up no joint cavity. And that the bones are connected together through dense, regular connective tissue. Bones connected with dense, regular connective tissue. Okay,
Okay, so no joint cavity and bones are connected with dense, regular connective tissue.
what about cartilaginous joints? Well, cartilaginous joints as well, they have no joint cavity. And in addition to that, it's cartilage that connects two bones together. So you have pad-like cartilage connecting two bones together.
So pad-like cartilage, PAD, pad-like cartilage that connects two bones together.
Pad-like cartilage connecting bones. Okay, and the last type of joint is a synovial joint, and that means that there is a joint cavity. And that this joint cavity has a synovial membrane, which releases synovial fluid.
So synovial, SYNOVIAL, has a joint cavity that has a synovial membrane that releases and secretes synovial fluid.
Synovial membrane and synovial fluid. Okay. So these are the three major joint classes, but of course they have some subdivisions of them. So first subdivision of fibrous joints is what we call a suture joint. Now a suture joint, as an example, is what you'll find with Frank here. If I were to take his skull off, if possible. If I were to have a quick look at Frank's skull, what we'll find is that apart from the hole that we put in order to hold the skull cap on, you can see a couple of little suture lines holding the parietal bones together and the frontal bone and the occipital bone, which is part of the lower aspect here. This is called the sagittal suture, and this is a fibrous joint holding those two bones together, which is a parietal bone.
So the sagittal sutures, SAGITTAL, I think, not two T's.
So we can say that suture, such as sagittal suture,
That's how you spell it.
the skull. Okay, what's another type? So we've got a suture, we've also got something called a gomphosis.
So GOMPHOSIS.
Now, gomphosis. How do we know where this is found? Well, when you see gum, think of gum.
It's the gum. I'm glad he said that because I thought I was pretty sure where they were. These are the ones that hold in your teeth.
G-U-M. Think of the gum. The gomphosis joint is simply the joint in which the teeth articulate in at the jaw. So, teeth in jaw. That's a gomphosis. And then the last type of fibrous joint is what we call a syndesmosis. And a syndesmosis joint, syndesmosis.
So SYNDESMOSIS.
Means to bind or to wrap. And so this is where you have connective tissue that wraps two bones together. So it's the connective tissue you find between the radius and the ulna. It's also the connective tissue.
It's the interosseous membranes. INTER, inter in between, osseous membranes.
Tissue you'll find holding tibia to the fibula as well. So that went back down. So you can say tibia fibula or radius ulna. That's the type of joint holding those two together. Okay, so they are the fibrous joints. Let's now move down and look at cartilaginous joints. We'll just separate that out. So, one type of cartilaginous joint is let's put two up here. There's going to be two particular types that we need to look at. One particular type of cartilaginous joint is a synchondrosis.
Did you find that one? SYNCHONDRO or DROSIS. Synchondrosis.
And the other type is a symphysis.
Guys, where have you seen the word symphysis? What about the pubic symphysis right here? That's an example of that joint.
Firstly, synchondrosis. You remember, so you got syndesmosis, synchondrosis. How are you supposed to know which one goes where? Well, chondrosis is going to be part of the cartilaginous, which means a synchondrosis joint is actually where you find cartilage within bone. So the type of place you find cartilage within bone is, if you think of the long bones, okay, you're going to have what we call a diaphysis. You know, the diaphysis is the shaft of a long bone. Then at either end, you have a proximal epiphysis and a distal epiphysis. Now, at the epiphysis, there is a line in here, which is called the epiphyseal line, also known as, when you're younger, the epiphyseal plate, which we generally refer to as the growth plate. This growth plate is made up of hyaline cartilage, which helps to secrete osseous.
So the epiphyseal plates or the epiphyseal lines are these joints.
Material cartilaginous material which then ossifies into bone and helps to grow the long bone. Therefore, synchondrosis is the epiphyseal plate. Which, as I said, is also just known as the growth plate. That's cartilage embedded within bone. What about a synthesis? Well, there's something that we call the pubic synthesis. And the pubic synthesis, if we have a look at Frank, for example, you'll find that here at the pubis, there's a bit of cartilage in between, and this cartilage is between this part of the hip, and that's what we refer to as going at the hip, part of the pubis, and this is what we call the pubic synthesis. Okay, that finishes the cartilaginous joints. I'm sorry about this little downward curve for my writing. Now we're on to the synovial joint. But what I want to do is I want to spend an entire video, maybe 5 or so minutes, talking about the synovial joint and using Frank as an example to highlight whereabouts you can find the synovial joint. Okay, so what you're going to find is that there's a number of synovial joints going from most free to least free, or least free to most free in regards to their range of motion. Just remember what you'll find with synovial joints is over synovial cavity, synovial membrane, and synovial fluid. But let's go back to those terms we were talking about before. The synarthrotic, meaning totally immobile, the amphiarthrotic, meaning partly mobile, and the diarthrotic, meaning mobile. So what type of joints are these? If you look at a suture joint of the skull, do you think this is not mobile at all, partly mobile, or fully mobile? Well, it's going to be immobile, not mobile at all. So you'd say that what was immobile? That was synarthrotic. So a suture joint is synarthrotic. What about a gomphosis for the teeth in the jaw? Well, you may think, yeah, I can wiggle around a bit, but you probably shouldn't be able to wiggle around a bit if you're the adult teeth. They should be quite strongly stuck in there. So this should also be synarthrotic. What about syndesmoses? What about the joint that's holding the tip, the radius and ulna together? Well, you can actually move those around. So I would say that that's partly movable, which is amphiarthrotic. What about a synchondrosis? What about cartilage between the bones?
Because amphi, if you remember when we talked about something as being amphipathic, do you remember that? Or amphiphilic, something that's partially soluble but partially non-soluble in water. So same thing here with amphitherotic. Partially movable, partially not. Synar is immovable. Syn meaning to come together and work.
Such as that would be epiphyseal plate. Well, that's not moving at all. So that's going to be synarthrotic. And then the last one here, the pubic synthesis, well, there's a tiny bit of movement that's available there. So you'd say that that is amphiarthrotic. You may be looking at this saying, well, when do we ever use diarthrotic? Diarthrotic is going to be saved for the synovial joints because synovial joints are all freely movable. It's just how freely movable are they? Sometimes they're moving.
So all freely movable.
One plane, sometimes they're moving two planes, sometimes they're moving many planes. And that's what we're going to talk about in the next video.
I think his name is Dr. Mike. At least according to the videos. I think we're going to be spending a lot of time with Dr. Mike today.
Now let's have a look at the synovial joint. So firstly, what is the synovial joint? I spoke to you about those various classes of joints, and I told you that you can have fibrous joints, cartilaginous joints, and synovial joints. I told you the first two, fibrous joints and cartilaginous joints, are quite immobile joints. Sometimes they're fully immobile, or sometimes they're partly immobile. But when we start talking about freely movable joints, what we're referring to are the synovial joints. And there's a couple of points about synovial joints which make them very specific and very particular. So what I've drawn here, to the best of my ability, is a synovial joint. So let's point out a couple of important regions anatomically and discuss what they do. So first thing I want to highlight is we have two long bones. So we have one long bone here articulated with another long bone here. So this could be either the humerus with potentially it could be the glenohumeral point, but it's not necessarily because it's two long bones, so it must be the knee, for example. So this could be where the tibia comes into the femur. Now, a couple of other things. These little swirls that I've drawn, this indicates the spongy bone, and then what you can't see towards the outside of the bone is what we call the compact bone. Now, I've filmed a video looking at the differences between compact bone and spongy bone, so please watch that. And you can see that in this little cavity in the middle of these long bones, which we call the medullary cavity, we've got some yellow bone marrow, which is fat. So the medullary cavity is one place that we can store energy in that form of fat. We've also got this little line that I'm drawing here on both of these long bones. Now, this is what we call the epiphyseal line, also known as the epiphyseal plate. And this is when children are growing up. I've spoken to you previously about in the epiphyses, so you've got the whole long bone, the diaphysis is the shaft of the bone, the epiphysis is on both ends, proximal epiphysis, distal epiphysis. And in this epiphysis, there is a plate that when you were younger, this plate was cartilaginous and would allow for bone growth to occur. So it would secrete all this extracellular matrix, and then calcium and phosphate would come along and harden that bone. So as an adult, this bone starts to ossify and harden, and it just becomes what we call the epiphyseal line. In addition to that, we can see the blue line that I've drawn, that's articular cartilage, which I've spoken to previously being of the subtype of hyaline cartilage, and it's this glassy, smooth cartilage at articulating bone surfaces so bones can glide across and create a frictionless environment. To aid in that frictionless environment, we have this membrane here, which is typical of synovial joints, and it's called the synovial membrane, and it releases a fluid in the joint capsule space called synovial fluid. And again, this fluid reduces friction. We've also got the fibrous portion of this capsule. So the capsule here is made up of the synovial membrane and the fibrous membrane here, which sort of encapsulates the whole joint part. You can also see we've drawn a little bit of a periosteum, which is the outside aspect of the bone. And the periosteum goes along the outside aspect of all bones. However, when it comes to an area of articular cartilage, there is no longer any periosteum, it then turns into articular cartilage. So now what I want to talk about are the different subtypes of synovial joints, how freely movable they are, and where you can find them in the body with the help of our friend Frank. So, firstly, when we look at the synovial joints, we can So what I've just done there is, in my own head, I've got a mnemonic for the joint, for the synovial joint. And a mnemonic is where you take the first letter of every word and you attribute it another word that's easy to remember in simply saying planar, hinge, pivot, and so forth. Okay? Now, usually I'll tell you what the mnemonic is, such as when we do the 12 cranial.
So planar, hinge, pivot, I think that's condylar. Do you see where these are on the worksheet? So classifying the types of synovial joints. Let me know when you find them.
It's page 5 of the worksheet.
And those we go, to touch and feel very good, velvet are heaven. For the epidermal layer of the integumentary system, we say, come, let's get sunburned for the 5 layers of the epidermis. Now this one, unfortunately, if I were to tell you, I would get fired because it's too disgusting for me to say. So in saying that, this is a good opportunity for you to create your own type of mnemonic. Now, let me tell you what these 3, 4, 5, 6 different types of synovial joints are. The first one is called a planar joint. The next one is called a hinge joint. Then we have a pivot joint. Then we have a condylar joint.
Mom, you guys, I don't, if my mom will provide permission, she got a melanoma removed yesterday. And I thought it was just going to be a very little removal. I didn't honestly understand why she wasn't allowed to lift more than 8 pounds for the next 2 weeks. But if she will be willing to show you the suture line that is much bigger than I thought it would be. Yep, it will be when do you want to put on another shirt? No. Okay. You guys see that? Nobody's answering. You lost all your students. I know. I always lose something like that.
Is it just steri stripped or is there like sutures?
It's sutures.
My goodness, that's too much.
Are they dissolvable or do you have to go back out and get them out?
I'll have to go get them out, but there's probably some internal sutures in there. They called it a complex repair on the notes that came home with me. So
all of that took about 45 minutes.
Well, when they go after melanoma, they take everything, you know, and it was supposed to be very localized, and they'll still take plenty of the subcutaneous fat, but it didn't go into any of the muscle or anything like that. So now I just have a weirdly shaped arm, and I'm happy to be rid of the fat. Okay.
Wow.
Any other questions?
So are you like a limb alert now? Like, should people not like get blood pressures out of that area? Like, I don't know. My brain just.
After it heals, it shouldn't be a problem.
Okay.
It's not like they've taken it. If they went after lymph nodes at some point, which they, you know, at this point, that's not a concern. I haven't been able to find any positive lymph nodes. We'll just have to wait for the results of this excision to see where we are on this beastie. Hopefully it'll never be heard from again.
I thought it was gonna be like a quarter-sized thing. I didn't realize it was gonna be like 5 inches.
Yeah, you'll have to measure it because I think they didn't identify it as being as big as it is on the notes.
Oh, really?
Yeah,
Wow. Holy cow.
yeah, okay,
Okay.
Thank you for sharing.
no problem.
You know, you're gonna have to share that with my class tomorrow too. Okay, just know, you've been warned.
You'll have to give me warning so I can.
Okay, that's just big. Yeah, it took all of 45 minutes. It wasn't any longer than that. They took you back there and it was done.
You knew her stuff.
The saddle joint
Um,
and the ball and socket joint.
Go ahead.
oh, is that him?
No, well,
Your-
it's a video.
Okay.
Go ahead. What were you gonna say?
No, I thought somebody was asking.
Okay.
Now, I've intentionally drawn up 3, 2, 1 because this is the order in which they go from least movable to most movable, or I should say, moving in the least amount of plane going to the most amount of plane. Let me tell you what I mean. Planar hinging pivot joints of synovial joints are uniaxial. Uniaxial means it only moves in one plane, either back and forth, up and down, left and right, etc. Condylar and saddle joints are biaxial. You can move in 2 planes, which means they can go forward and back, and up and down, for example. Ball and socket joints are multi-axial, and they're
You guys, multi-axial meaning they move in multiple directions. So uniaxial meaning they move in 2 directions. The one that was right here moving in 4 directions. This one meaning they move in multiple directions. Which ones are probably the most stable when it comes to not getting damaged?
Uniaxial.
Right. Which ones are the least stable?
Multiaxial.
Correct. So the thing that you have to remember with joints is the more movement you have at that joint, the less stable that joint is.
therefore they can not just move up and down and left and right and forward and back and diagonal and so forth. They basically can move in many dimensions. And you probably know what type of joint is socket. Okay, now a planar joint. A planar joint is basically like 2 flat pieces of material coming together, and they will either just move up and down or forward and back. That's a planar synovial joint. Where can you find a planar synovial joint? Well, let's bring Frank into the picture. The planar synovial joint is the type that you can find in the hand. Now, the hand has many different types of bones. So please remember that you will have your carpals here, your metacarpals here, and then your phalanges here. So carpals, metacarpals, then you can have your proximal phalanx, middle phalanx, distal phalanx. The place that you can find the planar joint is at the carpals, in what we call the intercarpal joint. So between carpals are where you can find planar joints. So we can write intercarpal joint. Intercarpal joint. What about a hinge joint? This one's pretty easy because you know what a hinge is. A hinge is something you can see on a door. And basically it moves the way my arm can move, which means that a hinge joint is the type of joint you'd find between the ulnar and the humerus. So the ulnar humerus joint here is a hinge joint. Okay, what about pivot joint? It's a pivot joint. Well, a pivot joint is basically when you have something like this, which can pivot around, okay, it's spinning around. So where can we find a joint that can spin? Well, if we have a
You guys, what if we talked about up here? Here in the upper part of the that could spin. Will allow you to move your head back to say, nope, I don't want that. So between the atlas and the axis, that little dent that's up here, that's a pivot joint. Basically,
look at Frankie again, let's turn around. If we have a look at his vertebrae, now, again, I've recorded a video on the vertebrae, so you can watch the video on the vertebral column. Very simply, you've got different types. So that's cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral, and coccygeal. And if you look at the 7 cervical vertebrae, the top 2, C1 or cervical 1, C2 cervical 2, quite different. The very top, C1, is also known as the atlas. Why is it called the atlas? Do you know that Roman god, I think it's a Roman god or Greek god, that's holding the world above him, holding that world up? Well, that's synonymous, or at least trying to be synonymous, with this atlas, the C1 holding the skull above it. The one below is called the axis. Okay, and the reason why it's called the axis is because it's spinning on the axis. So C1, atlas, holding the world above it. C2, axis, because it spins around, which means that C2, cervical vertebrae 2, is a good example of a pivot joint. There's a cervical vertebrae, sorry about my writing, C2. Okay, what about a condylar joint? So we're now moving into the biaxial realm. A condylar joint sort of looks like that. It sort of can rock back and forward and left and right. That's a condylar joint. So if we can have a look to see where we can find the condylar joint, okay, back again. Condylar joint is the typical joint that you'll find between the metatarsal and the proximal phalanx. So between the metatarsal and the proximal phalanx, that joint there is what we call a condylar joint. Metacarpal and proximal phalanx. Right, saddle joint. Think about somebody sitting on the saddle of a horse. Now, how does that look? Well, the saddle of the horse sort of looks quite strange. And then the joint coming in looks quite strange as well. So it's not the best drawing. Let me try that again. Obviously, I'm not the best drawer. I do apologize. But saddle joint sort of looks a little bit like that. Think of sitting on a saddle of a horse. Apart from that being so terrible, let me give you an example of where you can find a saddle joint. One simple place is, if again, you take the hand, and I'll do joystick from the hand, take the thumb from the metacarpal to one of the carpals here, which we call the trapezius. So the trapezium here, we go from the metacarpal to one of the carpals here in the thumb. That is going to be what we call a paddle joint. All right, last one, ball and socket. This one's easy. Think of a ball, think of the ball being inside of a socket. That's what you can find here, the glenohumeral joint. I'll bring back into the picture.
So the glenoid humeral joint, remember this is the glenoid cavity. So glenohumeral joint. Glenohumeral joint.
The glenohumeral joint, meaning the ball or the head here of the humerus. Think of the scapula here, glenohumeral joint, or even the head of the femur in at the hip. Both of these are examples of ball and socket joints. Now, even though they're multi-axial, some of these have less movement to others and some have more movement. So for example, the shoulder has greater movement inside of that joint, but it's weaker, while the hip has less movement inside that joint and it's stronger. Okay, so let's write down two examples of ball and socket. We can write glenohumeral. Humeral joint, which is the humerus and the joint of the clavicle. And we can also say the femur and hip joint. And these are examples of synovial joints. So hopefully with help of Frank, that was helpful for you.
So did you get the examples for each one of those on the worksheet? Somebody tell me yes or no.
Yes.
Okay. So types of movement. Find out on the worksheet. I know it's on there.
Welcome to anatomical yoga. We'll start at the top of our mat in anatomic position. Gently elevate and retract your scapula with ever so slight cervical circumduction. Now, flex your dominant hip and knee while an externally rotated contralateral hip and flex knee allow you to rest your foot on your thigh. Next, we'll move on to my favorite, the downward descent. If none of that made sense, then keep watching this video because today we're talking about movement terms. What's up, y'all? My name is Pat Kelly. I got another anatomy lesson for you. Today, we're talking movement terms. These are all the motions as they apply to the body. So we're going to go over what those movements are, what joints they apply to, and give you a few memory devices so hopefully you can remember them easier. I made this video to accompany my anatomical regions and directional terms videos. So if you haven't seen those, I'd recommend clicking that link right there to get a little bit of background. So here's the big picture. We have multiple joints that all move in incredibly unique ways. So simple terms like up, down, and sideways don't apply here. We need unique terms to describe unique motion. And when we're talking about anatomical motion, we reference an imaginary body in something called the anatomic position. That's standing upright with feet forward, arms by your side with palms forward, and head neutral looking forward. I've said it before and I'll say it again. Always refer to the anatomic position whenever you're talking about direction or motion. This is forever and always your starting point in anatomy. Why? Well, it's tempting to say something like move the patient's leg up to refer to hip flexion when someone is in the anatomic position, but that's a completely different motion than if they're lying on their side. So in order to standardize language, we always refer to the anatomic position. The second thing to keep in mind is that there are different planes of motion and different axes of motion with which these limbs and joints move around. Obviously, your body exists and moves in 3 dimensions. So while some motions seem like they happen in a very straightforward, linear way, most day-to-day motions are a combination of those. Let's start with abduction, which is movement of a joint away from the midline of the.
So you guys, what does it mean to abduct a child? When you think of someone on a child abduction, what are you thinking about? A taking away of that child from the family or from the parents. So abduction movement is a movement of taking that body anatomical structure away from the midline.
The body, and adduction, movements towards the midline of the body, specifically this midline on the sagittal plane. Now, clearly these words sound very similar, and some folks will painstakingly spell it out abduction to make it super clear. But the difference is actually way easier to remember. I picture an alien abduction taking my arm away from me, whereas with adduction, I'm adding to the size of my body. You'll see these motions all the time with shoulders and hips, but you can also apply them to fingers and wrists. In those cases, abduction doesn't necessarily mean going away from the body's midline, but from the midline of the hand. So really, finger abduction is the same thing as spreading your fingers, while adduction is closing them. One little note though, some clinicians will call this motion wrist abduction or adduction, but some will say radial deviation, meaning the hand is moving towards the radius, or ulnar deviation towards the ulna. They're the exact same thing, but since the hand and wrist are so often not in anatomic position, they're easier to remember this way. Next up is bending and straightening. More technically, flexion, which is a decrease in the angle between 2 joints, and extension, an increase in that angle. It's pretty intuitive for joints like the knee, elbow, or even spine, but some joints are a little trickier. Like this is shoulder flexion, and to me, it just looks like my arm is going away from my body. So I had to come up with a separate way to remember flexion versus extension. I remember that flexion is like the fetal position, which clearly both start with F. Check it out. The hips and knees are in flexion, the shoulders, elbows, and wrists are in flexion, and the neck and all parts of the spine are in flexion. That's right, flexion and fetal, the 2 best F words for any memory device. Extension is the opposite. You're increasing the angle between 2 joints, which usually results in straightening the limb or extending it past that frontal plane midline. But be careful because flexion and flexing are 2 very different things. When we say flex a muscle, what we're actually saying is to put tension on it, to contract it. And yeah, when you're flexing your bicep, you're also doing elbow flexion, but you can flex your quadriceps while you're extending your knee. Got it? Rad. Moving on. Next up is medial and lateral rotation, sometimes called internal and external rotation. And just like picturing rotation from physics, we first need to figure out what our axis is. So for both the shoulder and the hip joints, our axis is going to be an imaginary line running through the long bone of those joints. You can do this with me. If you stand up and lock out your elbow and rotate your shoulder so that your thumb starts pointing towards your midline, you've medially or internally rotated the shoulder. Now, on the flip side, the thumb is heading back out, so we're doing lateral or external rotation. Same thing with the hip joint. If you stand up and lock out your knee, when the foot goes towards the midline, that's medial rotation. If it goes out, lateral rotation. But remember, movement terms use the anatomic position as a reference. So if we're in standing, we can get away with using our hands and feet as little guides, but that might completely disappear if we have our person change position. Like imagine for whatever reason you wanted to assess a patient's internal shoulder rotation in a seated position. It's going to be really difficult to work with a straight arm, so you have your patient bend their elbow. Now, in this case, internal and external rotation still make intuitive sense. My arm is going towards the midline or away from the midline, which agrees with the long axis rotation we defined earlier. That's awesome. Unfortunately, that doesn't translate to the hip joint. Right here, I'm actually doing medial hip rotation. The long axis of the femur is rotating towards the midline, but my lower leg is all out to the side. Vice versa when I do lateral rotation or when you test this in the supine position. Okay, lesson learned, if you look at the long axis of the bone in anatomic position, you'll never trip up. So those are our major multi-joint movements. But there are some exceptions, and from here on out, it gets pretty specific. Like the radius has the ability to flip around the ulna due to a cool little pivot joint between the radius and ulna that's totally separate from shoulder rotation. This is called supination and pronation. Supination, everyone remembers because you flip your hand up like you're asking for soup. It gets dumber. On the other hand, I remember pronation because it's like a bunch of pro national football players all putting their hands in on the pile. Also, can I get credit for putting literally the other hand in? But it gets even weirder and more specific. Like the ankle joint, specifically between the talus and the lower leg, do something called dorsiflexion and plantar flexion. I remember these because when you point your toes down, you're planting your toes on the ground. Then when you point them back towards you, you're pointing them towards your dorsal aspect, your back. Or
dorsiflexion, you're bringing the back of your foot up towards your ankle. Plantar flexion, even more silly than what he had there. You're planting, if you're going to plant a seed with your big toe, plantar flexion. Dorsiflexion, you're bringing the back of your foot up to your tibia. Remember that the side that has the fingernails or the toenails on it is the back of your hand or foot.
Where we'd keep our dorsal fin, but the ankle can still wiggle a little more. That same talocrural joint rotates around the long axis of the metacarpals to do inversion and eversion. Easy way to remember those, if you invert your feet, your body will trip over and your body will end up inverted too. But you could forever comfortably stand in eversion. We're getting to the end, but lastly, we need to look at the scapula. They can elevate or depress, protract or retract, all of which are pretty intuitive to remember. Finally, we have circumduction, which is this big, silly-looking circular motion that happens at a few joints, including the neck, shoulders, and hips. Now, those are all the major motions, but
circumduction making a circumference.
But there are a couple things to keep in mind. As a clinician, you're probably going to care about these movement terms because they're going to help you document things like range of motion and functional movement. Usually we care about three types of movement. Active motion, which means the patient is moving the joint through their own effort. Passive motion, which means the motion is being done to them either by your hands or by a machine. And resisted motion, which is self-explanatory. Some kind of resistance is being placed on that motion. And those are important distinctions to make because that might help you with your assessment. For instance, if somebody had painful active shoulder flexion, but they were fine on passive shoulder flexion, you can use that information. Now, all anatomy students are going to need to know these movement terms, but if you're more interested in movement itself, I'm going to recommend this playlist up here. It's my musculoskeletal biomechanics and kinesiology playlist. Specifically, I'm going to recommend this video about origins and insertions. I think it'll be really helpful to you. And a big thank you to David, who's my newest patron on Patreon. If you want to join him, you can click that link there, or you can support the channel for free by subscribing at that link there. Have fun, be good. I'll see you next time.
So find on the worksheet where the knee model is. When you found it, let me know.
It's on page 6.
This is a model of the knee joint. It is classified structurally as a synovial articulation. This particular synovial articulation is a hinge joint, although the knee is kind of considered a modified hinge joint. Since when flexed, it can also demonstrate gliding movements and rotational movements, but mainly it is a hinge joint. Because this is a synovial joint, it consists of a synovial cavity that is going to be filled with synovial fluid. That synovial fluid is produced by a synovial membrane called the synovium, and that synovial fluid acts as a lubricant to reduce friction. It permits a greater amount of movement than either like a fibrous joint or a cartilaginous joint. The majority of joints in the human body are synovial. So other examples besides this knee joint would be something like the shoulder joint, the elbow, or the hip. Functionally, this joint is freely movable, and so it is classified as a diarthrosis, which means freely movable. We're going to look at this anatomical model, the knee joint, because it has the distinction of being the most complex and highly stressed joint. So this is a location for lots of many joint injuries. If we look at just some of the those extracapsular ligaments, those ligaments that are made up of dense fibrous connective tissue that are sitting outside the synovial cavity, the articular capsule, we see that we have what is called the tendon of the quadriceps femoris, the tendon of the quadriceps femoris. And remember that a tendon is going to attach muscles to bone. The bone that it is attaching to is the patellar bone. And so you can see the patella here. I'm going to leave it here for just a minute, but I'll take it off in a second. And so the patella, which is also known as the kneecap, is the largest sesamoid bone. And so it attaches to 4 muscles that insert into this tendon. So this group of anterior thigh muscles are called the quadriceps femoris, and it consists of the rectus femoris, the vastus lateralis, the vastus medialis, the vastus intermedius, and all of these then.
So vastus medialis, vastus lateralis, vastus intermedius. Rectus femoris on top of it.
Insert into this tendon which attaches to the patella. Going down inferiorly, there is another ligament, and this is called the patellar ligament. A ligament attaches bone to bone. So it attaches the patella to the tibial tuberosity of the tibia. You can see that this joint consists of 3 bones. So there is the femur, which is the large thigh bone. There is the tibia, which is the thick inner bone of the 2 lower leg bones. And there is the patella. The fibula is here, but it does not articulate with the femur. Just the tibia, the patella, and the femur all articulate with one another in this joint. Although the fibula is important because it serves as an attachment point for some of these extracapsular ligaments. If we take off the tendon of the quadriceps femoris and we kind of open up the knee joint. So now you can see here that we have the patella, and you can see this flat surface is going to articulate with the patellar surface of the femur. Here we see that we can see that at the distal part of the femur, we have the lateral condyle and the medial condyle, and we have the medial condyles and lateral condyles of the tibia. These are all covered along with the patella. They are all covered with a specific kind of cartilage called hyaline cartilage. But because the hyaline cartilage is located at an articulation, we call it articular cartilage. So that is what you're seeing here. The ends of these bones are covered with articular cartilage. The ligament that is located laterally is called the lateral collateral ligament. If I turn it to the side, you can see this lateral collateral ligament, or we can call it the fibular collateral ligament. It attaches from the lateral epicondyle of the femur to the head of the fibula. And then if we turn the joint so that you can look at the medial surface, we can see the medial collateral ligament, or we can call it the tibial collateral ligament. So this would connect the epicondyle of the femur to the condyle of the tibia. If we open up the joint and we pull down the tendon of the quadriceps femoris and we look inside, we can see that sitting on the condyles of the tibia are discs of fibrous connective tissue here and here. And so these are covering the condyles of the tibia. So we would have the medial meniscus here, and we would have the lateral meniscus here. And these are important because they act to cushion the knee joint. Since we are looking at the anterior portion, anterior surface, we see the anterior cruciate ligament. And so it comes from the posterior.
Cruciate meaning cross. So you have an anterior cruciate ligament that's going to come from the back to the front. Actually, I think it's the reverse, from the front to the back. And you have a posterior cruciate ligament, and they're going to come together and they're going to cross. And someone talks about blowing their ACL. This is what they're talking about, is the anterior cruciate ligament. Their PCL, their posterior cruciate ligament.
Surface of the femur and attaches anteriorly to the tibia. And so this adds strength to the joint anteriorly. This is going to cross or make an X-shaped kind of structure. If you were to look deep inside, you can see there is an X-shaped structure. So here's the anterior cruciate ligament. And then back here, we have the posterior cruciate ligament. So the anterior cruciate ligament is kind of going back from the anterior part of the tibia back to and inserting on the posterior surface of the femur. And if we turn the model around, then you can easily see the posterior cruciate ligament, which is right here. Posterior cruciate ligament. And so this adds strength to the joint posteriorly. The posterior cruciate ligament and the anterior cruciate ligament, again, they cross, and that is what is giving us the term cruciate. And so they're going to help to stabilize the knee joint from any side to side movement.
So anterior cruciate ligament, posterior cruciate ligament. Medial collateral ligament. Lateral, medial meaning towards the midline on the collateral side. Lateral collateral ligament. And I'm sure you've heard of someone saying they've blown their anterior cruciate or their posterior cruciate, their PCL or their ACL, their MCL, that LCL.
There are 4 major ligaments that stabilize the knee. The medial collateral ligament is on the inner side of the knee, and the lateral collateral ligament on the outer side. The collateral ligaments give sideways stability to the knee. Two ligaments cross in the center of the knee. They are called the cruciate ligaments. The ligament toward the front is the anterior cruciate ligament, or ACL, and the one towards the back is the posterior cruciate ligament. The ACL prevents the lower bone, the tibia, from moving forward, and the PCL prevents it from moving backward. If the ACL tears, the tibia can move forward too much, and the knee can be unstable. The knee in which the ACL is torn tends to give out when pivoting or quickly changing direction. To correct this instability, a new ACL can be made. The strongest graft that is available to replace the torn ACL is the middle third of the patella tendon. This graft has a plug of bone taken from the patella or kneecap on one end and from the tibia on the other end. These plugs of bone are important.
So the middle third of the patellar ligament.
Because they provide solid fixation of the graft. This animation will explain how the middle third of the patella tendon is used to reconstruct a torn anterior cruciate ligament. We now move on to the knee joint, where we'll describe the knee joints, including its osteology, ligaments, and its movement. So the knee joint is also a synovial joint. It's considered a hinge joint or a bicondylar joint. The two articulating surfaces are the femoral condyles that articulate with the tibial condyles. Together they make this hinge joint, called a bicondylar joint because we have two femoral condyles articulating with two tibial condyles.
That's massive.
Primarily giving us hinge joint movements of bending in only one plane, but we'll see that it gives some rotational movements later on.
45 minutes.
Bicondylar joint. Now the ligaments, there's a lot of support to help with this knee joint. We've got two cruciate ligaments, we've got two collaterals, and we have two menisci. The first is the anterior cruciate ligament we'll talk about. It arises from the anterior surface of the tibia, and then it inserts on the posterior part of the distal femur. We also have the posterior cruciate ligament that arises from the posterior part of the tibia and inserts more eventually on the femur. So the cruciates get their names for the part of the tibia they arise from. The ACL arises from the front of the tibia, the PCL arises from the back of the tibia. And you'll notice that if we put them both together, they make a cross, hence the name cruciate, which means cross. Anterior and posterior ligaments that make an X or a cross within the center of the knee joint. Now, the functions of both of these ligaments can best be demonstrated in this lateral view of the femur tibia, and you can see the patella that shows the front of the knee joint. Now, this anterior cruciate ligament, it restricts anterior displacement of the tibia on the femur. Sometimes that is restricts anterior translation of the tibia on the femur. In this fashion, when you see the femur moves forward, notice that the ACL becomes taut, tight, helping to restrict that forward movement of the tibia. In contrast, the PCL restricts posterior displacement of the tibia on the femur in this fashion. When the tibia wants to move back, the PCL helps restrict that movement. Hence, anterior posterior cruciate ligaments help with restricting anterior and posterior translation of the tibia on the femur. Now, our two collaterals are lateral collateral ligaments arise from the lateral epicondyle of the femur and goes to the head of the fibula. And this ligament, we'll talk about that in a second. Then there's the medial collateral ligament that comes from the medial epicondyle of the femur and goes to the medial proximal tibia. And so the functions of these are best illustrated in these pictures. So that lateral collateral ligament prevents varus or varus forces on the knee joint. So what that means is lateral bending or bending of the knee joint towards the wall. That's a varus force. And what this lateral collateral ligament does is help prevent that lateral lateral bending of the knee when a varus force is applied to it. Then, in contrast, that medial collateral ligament prevents valgus forces on the knee joint, which is forces that will bend the knee more medially towards the midline of the body. So the MCL prevents medial bending of the knee joint when a valgus force is applied. And then our menisci. These are fibrous cartilage or fibrocartilage wedges that are found within this knee joint. The medial meniscus is illustrated there in purple, and then the lateral meniscus as well. And these menisci help with absorption of shock and help keep the femoral condyles on the tibia when the knee is bending. So the movements of this knee joint are extension, flexion, and then we discuss this rotation. So extension is straightening the knee so that the knee becomes straight. The primary muscles that will do this are our four quadriceps muscles. They're the primary extenders of the knee joint. And then flexion of the knee joint is primarily from our hamstrings, semimembranosus, tendinosus, and biceps femoris, and you get a little bit from the gastrocnemius muscle as well. And then our rotational movement, so this is one that is a little less, it's a little more subtle in noticing it, that when you are standing and your knees are bent, when you stand up and you straighten, your knees lock. And that helps reduce the amount of energy expenditure your muscles require to keep standing. So whenever you bend and completely straighten your knees while standing, your knee joint rotates just a bit, enough to lock your knee. And then that will enable you to reduce the amount of energy your quads and hamstrings would require to stand up straight. And the popliteus muscle, when it contracts, helps to unlock or unrotate that knee joint. By doing this, you put more tension on that fascia that's on the back of the popliteal fossa, which then can help put pressure on the popliteal vein, possibly preventing return of blood. And that's why some people who stand at attention for long periods of time can sometimes become faint because of that pressure in the back of the popliteal vein.
So, Jen, have you ever seen someone pass out while you're standing in formation? I know she has, and I know she's here. I'm sure she has. I don't know where she is. But if you remember, Jen's the one in the National Guard. So I'm thinking, I know I've seen it. My siblings have talked about people passing out while standing in military formation. You guys, let's take 10 minutes. And then we'll go through the PowerPoint and go forward from there.
Sounds good.
Don't lay out your picture on right now. Don't lay out your picture on right now. I have 10 minutes. Okay. So my understanding is almost kind of back to your kind of like my going on the back of my arm. I can feel it really. Okay, then go feel it. I'm ready to use it. So how big did they say it was on the yeah, that's how big. No, it's not 3 or 4 centimeters. Going to fortify it. Mary, if you've got a minute, can you run the dogs out? What? If you've got a minute, can you run the dogs out? And then I can get over to Marcy. Courtney, would you quit logging out of the meeting?
I swear I'm not doing it on purpose.
You know, I didn't even know whose phone number it was. I like, but you know, 2 times in one day.
Yeah, first time wasn't my fault. My laptop likes to not tell me when its battery's low, and I forget to check it. All of a sudden, it's like, boo! I'm like, what the heck just happened?
God.
And the second time was my fault. I hit leave meet. It was a different block, and I was like, what's this? I'm like,
go ahead, Courtney, keep trying to make excuses.
I know. I was just having a bad day. My coffee didn't set in. I'm sorry.
Okay, let's see here. Okay. Oh, that wasn't what I wanted to do. Come on. Jen, I see you're already back. I thought you weren't coming back until next week. I know she's here. I thought she was. I saw her name come up.
Yeah, I don't see her now though. Maybe she's pulling one of my things.
Probably. You know, you guys are both troublemakers. Always causing chaos.
Makes life more interesting.
It's true. It's true. Okay. Yeah. And Chloe, when you sent me that text yesterday and you asked, you said who you were, I thought at this point in the semester, I know who you are. And it made me smile because I was like, you know, at this point in the semester, I can pretty much tell you I know who everyone is and which class they're in.
Well, that's good. I like to say who I am just in case, because some of my other teachers, I just like them to know who I am.
Yeah, I thought I know who she is.
Professor, I texted you like, many times and you still don't know his gems.
But you know what? I'm pretty good with names. And once I start to learn names, I may not remember which class you were in like 5 years from now, but I can tell you that I know who you are. When we talk, I have an idea. I may not have ever seen your face, but I know your name.
Okay.
So joints and synovial joint movements. So hyaline cartilage, it's on the surfaces. You remember it looks kind of glassy in its histology, because that's what hyaline means, is glassy. And it just allows for smooth movement on that joint. If you've heard of people talking about who have joint problems saying that it's like bone on bone, that's a lot of times it's either hyaline cartilage or fibrous cartilage that's missing. elastic cartilage, the auricle of the ear, the epiglottis keeps you from choking. The cuneiform cartilages of the larynx, the auditory tube, pads within the knee joint between the pubic and pelvis bones. So this would be the pubic symphysis, the intervertebral disc. What is an articulation joint? A joint that connects. So this is one of you, I know this is one of the questions, I think it's on the first page. A joint connects bone with bone. Bear with me just for a second here. A joint connects bone with cartilage. A joint connects bone with a tooth. So I think that's on the first page, right? Sound about right?
Wouldn't a joint connecting a bone with a tooth still be a bone to bone because a tooth is a bone?
It's not technically, there's more to a tooth than just bone. It's actually not technically, I mean, we're not going to spend a lot of time on the special senses, so we won't spend a lot of time on teeth, if at all. But it's not, it doesn't, it's not a bone in a lot of ways. What? Say it one more time, Mom?
Yeah, because it has the pulp and the dentin and all that.
Yeah. It doesn't have the same properties as bone.
Yeah.
Joints can be classified functionally by their degree of movement. Synarthrosis, remember synar meaning union, and immovable joints, the fibrous joints of the skull. Amphiarthrosis, a slightly movable joint, like the pubic symphysis that moves slightly to allow for the baby to come through the pelvic cavity. Doesn't move much else than that. Diathrosis, I'm trying to remember how he said it, diathrosis. A freely movable joint, you're least stable. So these are your most stable, these are your least stable. The more movement you have in that joint, the less stable that joint is.
I have a question, Professor. When you were up there with the tooth, when it said what kind is that? Was that cartilage? Yeah,
it's a synarthrosis.
Okay,
so is what you were asking about? It's this kind of joint.
Okay.
I can tell you that I think I might have mentioned this, and I know I mentioned it several times that I broke my jaw like almost 20 years ago. At this point, it's been 19 and a half. Yeah, 19 and a half. And my joints, I'm losing some of my teeth. And it's part of the fact is that where the break was, and because the bone remodels every time. And part of it is that because I've broken on both of the joints, the doctor who put my jaw back together again, and it was an open and complete fracture, so it was a mess. And when he put it back together again, something about it didn't connect with him that my jaws were out of alignment. And so they filled out of alignment, and the fact that I have a bite that puts pressure on this side of my lower jaw, that's also causing me to lose those teeth. And it's a risk to benefit ratio where they won't go in there and they won't re-break the jaw to shift it back into alignment. And so when he was talking about synarthrosis, all my teeth, at least from about right here over, actually, I don't think my back molar, but from right here over are all movable joints at this point. And they're actually pretty easily movable, which is not a good thing, but they're actually very healthy. And so I'm just kind of letting them, I'm keeping them in there as long as possible. And I'll eventually most likely lose all of them from there on over. And so when he was mentioning that, I thought, not me. But he did mention that in normal, healthy people, adult people, they're not supposed to move like that. So sadism, sin, amp, die, immovable, slightly movable, sadism. It's a good way to remember it. Joints that can be classified structurally. Fibrous joints. Fibrous connective tissue holds the joints together. Mostly immovable, so synarthrosis. Some have slight movement. Most, don't know what that was going to say underneath. Wraps the two bones together, that interosseous membranes, interosseous ligaments. So it would also be a fibrous joint, this spondylosis. Cartilaginous, bones held together by a plate pad of hyaline cartilage or fibrocartilaginous disc. No fluid in between. The epiphyseal plates. The joint between the ribs and the sternum. Manubrium. Most are amphiarthrosis, except cartilaginous epiphyseal plates of long bones and joints between the rib and the sternum are synarthrosis. Synovial, freely articulating, so they're all diathrosis joints. Freely articulating bones, fluid-filled capsule held together by ligaments. Most complex of all joint types, all are diathrosis. Synarthrosis examples. Amphiarthrosis. Synovial cavity, small space between two articulating bones. articular cartilage, hyaline cartilage that covers the ends of the bones in the synovial cavity.
So now the synovial cavity, would that, or I'm sorry, synovial cavity. So synovial, would that be like your elbow?
Uh-huh.
Okay.
Have you ever seen someone get a bursitis?
No, I don't think so.
They're pretty nasty if you've ever banged your elbow joint and then you get a swelling right in that area. It's inflammation of the bursa in this area, which is, I hope they show it here. It's a sac of like a spongy fluid.
Okay.
And it normally goes down with time. Bear with me just a second. I'm gonna look really quick, see if it's here. Yeah, right here. So fluid-filled sacs. You will see them when they get banged, when you get damaged. You can get it on your knee. You can get it anywhere where you have a synovial joint. You get that, it gets banged and it swells up because it's a bursting of that structure.
Okay, that makes sense.
And it will heal most of the time. If it doesn't heal, you may have to get the fluid drained out because it can calcify. Articular cartilage, hyaline cartilage covering the ends of the bones in the synovial cavity. Articular capsule, structure that encloses the synovial joint and synovial cavity, has two layers: the fibrous membrane and the synovial membrane. Fibrous membrane, outer dense fibrous connective tissue layer of the articular cartilage. The inner membrane is the synovial membrane that secretes the synovial fluid into this cavity. Fibrous membranes continuous with the periosteum. This dense, irregular connective tissue. Synovial membrane composed of areolar connective tissue. Synovial fluid secreted by the synovial membrane and lubricates the articular cartilage to reduce friction. It also supplies oxygen and nutrients to the cartilage while removing carbon dioxide and metabolic waste. Periosteum, fibrous membrane, synovial membrane, synovial fluid, hyaline cartilage, ligaments, bands of dense, regular connective tissue, like tendons that join one bone to another bone. Bursa and tendon sheaths are fluid-filled structures strategically placed to minimize friction in some joints. Right. You guys bear with me for one moment, okay? We got that. She's got this over there? Yeah. Okay. That doesn't stick. Thank you. thought it would be better, but obviously not. In some joints where hyaline cartilage predominates, the pads of the dense fibrocartilage called menisci. Let's see here, we didn't finish this. So bursa and tender sheaths are fluid-filled structures strategically placed to minimize friction in some joints. In some joints where hyaline cartilage predominates, the pads of the dense fibrocartilage called menisci are also found between the articular surfaces. These articular surfaces provide superior strength and allow bones of different shapes to fit together more tightly. Types of synovial joints: the pivot, the ball and socket, the condyloid joint, the plane joints, the saddle joints, the hinge joints, uniaxial only moves in one plane, back and forth, up, down, left to right. So planar, hinge, and pivot. Biaxial, condyloid or saddle. One bone is rounded, one of them is more like a cup that allows the rocking motion between the two. A saddle joint. Multiaxial moves in many planes. Even though these are multiaxial, some of these joints have more movements than others. The shoulder has the most movement, but it's the weakest. The hip joint has less movement, but it's stronger. So the more movement you have at the joint, the less stable or the weaker it is. Go ahead.
Sorry, I was just on the worksheet. It's asking to give examples of where you'd find certain synovial joints, and it's planar, hinge, and pivot. Hinge, would that be the finger?
The hinge would be like your
elbow.
Yeah, it's also your knee and your ankle. Why don't I wait right a minute? You guys, this is so planar, hinge, and pivot. Here's the examples for the planar, the sternoclavicular. Remember, that's where your sternum is meeting up with your clavicle. Your vertebrocostal, where your ribs are meeting up with your vertebrae. Your joint between your scapula and your clavicle. Hinge joint, elbow, knee, ankle. Rotation around a single axis between the dens, the axis of the atlas. The proximal radial ulnar. Right here. The distal radial ulnar. condyloid, the metacarpal proximal phalanx joint, joint between the radius, scaphoid, and lunate bones. The saddle between the trapezium and the thumb, the metacarpal. Ball and socket between the head of the femur and the acetabulum of the coxa. The glenohumeral joint.
All right, thank you.
You're welcome. Flexion, extension, flexion meaning decreasing the angle, extension increasing the angle. Hyperextension, taking it beyond that angle, past the anatomical position. So here's the plane right here. Right, 180 right here, 180 line flexion. We're decreasing the angle from 180 to 90. If this is the plane right through here. Extension, I'm bringing it back to 180. Hyperextension, I'm taking it beyond 180. Adduction, I'm taking the arm away from the midline. Adduction, I'm bringing it back. I don't know if that's still. Circumduction. Don't know how well you saw that. For some reason, I don't see my video either. Rotation.
Can you go back to the image quick, please?
Yeah.
I'm good. Thank you.
Okay. Rotation on the atlanteal-axial joint between the atlas and the axis in the neck, the C1 and the C2 vertebrae. The shoulder joint, medial rotation, bringing it towards the midline. Lateral rotation, taking it away. Gliding movements, simple back, forth, side to side, back, forth, side to side. Elevation, depression, protraction. This is one thing that I can't do with my jaw so well anymore because of that out of alignment and the fact that the TMJ joint is messed up. Is I can protract it out a little bit, but not very far. Retraction, bringing it back. Protraction, bringing it back. Inversion, bringing your foot show you it all. Inversion, bringing it into the midline. Eversion, bringing it out, away from the midline. Plantar flexion, trying to plant a seed with your toe. Big toe is going to allow you to plantar flex. Make a hole for the seed. Dorsiflexion, bringing the front of the foot upward. Bringing the back of the foot upward towards your tibia. Pronation. Pronation, you're more prone to spill the bowl of soup. Supination, you can hold a bowl of soup. Opposition, being able to oppose your little finger to your thumb. Oppose them. Knee joint, modified hinge joint, the most complex and highly stressed joint in the body. I know for people who are more heavy set, they will tell you that their knees tend to hurt, and if they lose the weight, they'll notice that their knees don't hurt as badly. Lateral, collateral ligament, medial collateral ligament. In the middle, in the center, anterior cruciate ligament, posterior cruciate ligament. Patellar ligament. Fibular collateral ligament. Coming down over the fibula. So the condyles. The lateral collateral ligament, menisci. The posterior cruciate ligament, the anterior cruciate ligament, number 4. 5 is the posterior menisci, the medial collateral ligament, I think I named them all there. Posterior cruciate ligament, anterior cruciate ligament, medial collateral ligament, lateral collateral ligament, patellar ligament, quadriceps tendon, lateral meniscus, medial meniscus, fibula, tibia, patellar ligament, medial meniscus, lateral meniscus, medial collateral ligament, osteoarthritis, common in large weight bearing joints such as the knees, the hip, and the spine. The cartilage that protects and cushions the joints breaks down over time. As the cartilage wears down, the bone surfaces rub together. It's called bone-on-bone joint disease. It damages the tissue and bone, which then causes pain. The joint space in this hip joint is narrow due to cartilage loss and bone spur formation. Artificial acetabulum, artificial femoral head, artificial metal shaft, where they pound this thing into the head of the femur. The hip socket component is placed, the femoral component is placed, the hip replacement is complete. Total knee replacement. They put in fake condyles, metal condyles, a plastic spacer, and the tibial component, and the patellar component. Probably, from what I've heard, one of the more painful surgeries you can ever have. Hip replacements are pretty painful too. You guys, that's the end of the PowerPoint. Do you want me to put you into breakout rooms? How many people do we have? We have 16. You
want to?
All right, I'll put you into 2 breakout rooms. And just feel free to leave at 10:45. As soon as I get my act together.
Professor?
Yeah?
Yeah, I actually sent a message for you. I want to leave the meeting because I have some my son's school issues. You have to go
Go
there.
for it. That's fine. I understand.
Thank you.
You're welcome. So obviously that tape doesn't work.
It doesn't have any sticky on it, so you can't take
We'll
the wrapping
return.
on it.
I'll,
It's the wrap thing.
I'll return it. Because it was $6 before for the 2 rolls.
I knew it was going to be that kind of, it's not what we need.
Okay. I can't return it today. Okay. I wonder if my National Guard student was actually joining us from somewhere besides this area, because her internet dropped out. She wasn't supposed to be back until next Tuesday. Or next Monday. Or next Wednesday, somewhere in there. So I was kind of surprised to see her today. And then it dropped out anyway. because I brought it in from last night. That's why we needed a pet rock. Very important. Everybody has a pet rock, Mother. So you give it to your dogs instead? Mother, if you don't like it, what makes you think they like it? Mother, you take advantage of the moment, Mother. Oh, I'm tired today. Yeah, you say that, but obviously you don't like drinking it. I can't, I don't even tolerate it like that. Oh, I can't say that I'm ever going to join you on that bandwagon. Because I can definitely taste the difference in the water. Huh. Well, I remember Casey came here, and when I gave him a drink of water, he was like, "That's good water. That's yummy water." Oh, what kind of water do you have? Makes you wonder what he's so happy about the way the water tastes.
Professor Gessel?
Yeah.
I actually have a question for the Lab 11 worksheets.
Uh-huh.
I didn't finish mine yet, because I had a question about I think I remember you saying it, but I just wanted to verify it.
Yeah.
For the part that you have to have a partner.
Don't worry about it.
Don't worry about that part?
Yeah.
Oh, okay. I was like, I have my daughter that I can try to do it on, but she's really little.
You know what, it doesn't, that works great in the lab when in a right typical class when you have multiple people in the classroom. It doesn't work so well here.
Okay.
Case study 3 has a lot to do with that. So, but yeah, so don't worry about it.
Okay, thank you.
You're welcome, of course. How old's your daughter?
She'll be 2 in January.
No, probably wouldn't work right. She might be patient enough to let you pull it off, but maybe not.
No, I don't think she would be. She's a wild child.
Well, of course she is. That's she's supposed to be.
Yeah. She gets it from my husband.
Oh yeah, blame it on him. It didn't come from you at all.
Oh, I really want to see your x-ray sometime.
Let me see if I can't find it between now and next Monday. I know where it is. I don't know how well you're going to be able to see it. But yeah, let me see if I can't. Let me look for it because I have an idea where it is and I just need to pull it out. I don't know how well you'll see it though.
Oh, okay.
I'll try.
I'm going into dental hygiene.
Oh, really?
And I was an orthodontic assistant for 3.5 years. So
it was a pretty amazing break. And, you know, and I don't, you know, the fact that my jaws are out of alignment now and that I struggle with certain things, I don't blame the surgeon because trying to put that back together again was a pretty incredible feat all in itself. And I'll let me see if I can find it and I'll show it to you.
Did you have did you break the condyle of your mandible, or do you have flattening of your condyles now?
I don't know. I can't see that. If I do, I can't see it. What I have the panoramic, and if I do, I can't see it. And I've never been told that I do, but you can tell when you go like this and you can tell that it's off and that it doesn't move the way it's supposed to.
Gotcha.
Yeah, it's supposed to open and slide forward. And mine, this side does not do that to the extent that this side does.
Gotcha.
Yeah, but let me see. I mean, I think if I find a piece of white poster board, because it's about this big. If I find a piece of white poster board, you should be able to see it fairly easily. But yeah, I will pull it out. I'm sorry. I've thought about it and then I've never done it. And I think I told you I would show it to you and I've never done it. So let me find it.
Did you ever get an orthodontic consult?
I did. And they were the ones who they considered going in and re-breaking it. But because I already have shallow roots on my teeth because I have a cleft lip and palate also. And when I was about 12, 13 years old, they went in and broke both of my jaws and shifted them to give me a better bite. And when they do that, every time that you break a bone, it remodels. And with that, it already gave me shallow roots on my teeth. Breaking my jaw the way I did with my next break gave me even shallower roots on my teeth. And so they decided that if they went in and rebroke it again or tried to put braces on me, my teeth are not stable enough to stay in there and handle the pulling. And that they would probably all fall out. And so when I go in right now, they talk a lot about, well, I have a great dentist. I actually go to Frederick to meet with a dentist because I've struggled a lot with dentists over the years because sometimes they get in my mouth and they think that I'm a very neglectful patient. But Chloe, I have more dental brushes and more toothbrushes and more flossing than most people will ever have. And so they go in there and they think, oh, well, obviously you need some periodontal work, but I have very healthy gums. I'm very persnickety about the toothpaste that I use. I'm very careful about the toothbrushes that I use. And once they realize just how clean my mouth is, they don't say anything. Yeah, my mom says I'm very meticulous in my toothbrushing.
Yeah.
But I use, you know, I don't only, I'm very specific. I only use like the Crest Pro Health or the Parodontax toothpaste. And I did the research and found out that the Crest Pro Health has the same active ingredient as the Parodontax has. And so I only use the Crest Pro Health.
Gotcha.
And growing up, I had lots of cavities because cleft lips and palates tend to have softer teeth, and so growing up, I had a ton of cavities all the time. And as an adult, since I switched to the Crest Pro Health, I don't have any cavities ever. I have very little plaque buildup, and it's been pretty amazing the difference. You know, that I go in, and even if I off and on, I've had insurance, and I finally paid for an insurance through my dentist. But even if I go a year without getting a cleaning or 2 years without getting a cleaning, I don't have a lot of plaque buildup. And so I struggled at times with dental hygienists and people not being very nice with me initially when they're looking in my mouth, because they're thinking your teeth are so movable. Obviously, you don't take care of them.
Yeah. A lot of people, there's so many factors that factor into that. Like one thing that I learned is that acid reflux can, like break down your teeth.
Yeah, because the acid.
Yeah.
It's nasty stuff. I've never dealt with acid reflux. I don't think I've ever dealt with heartburn. But people who deal with acid reflux are at much higher risk for esophageal cancers because it's constantly burning their throat.
I had a little boy as a patient one time, and his baby teeth were just they were just worn down to the pulp, because he had acid reflux all the time.
How old was he?
6.
You know, and that's hard. I can't imagine I know that little kids tend to have more acid reflux, babies, and I can't imagine what that feels like.
I felt so bad for him.
Yeah, wow. No, this dentist that I went to, the first thing he did, and this is why I travel an hour to see my dentist, is the first thing he did was he took panoramic. That was the first thing he did before they did anything with my mouth.
That's what we do where I worked.
Really, I appreciated it because the second he saw me, he knew he was in for an interesting case. And the second the dental hygienist saw me, they knew they were in for an interesting case. And so every time I go in there, I learn something new. I mean, I didn't realize until this most recent appointment when the dentist was telling me that it's not just the way the bone broke. It's the fact that the jaws are out of alignment and the way I'm biting regularly, whether I want to or not, the way I'm biting down on them is causing them to loosen up.
Yeah, and I'm sure you're unevenly wearing on that side that you chew.
Yeah, you can't see, but if you look right here, my bottoms they're in at an angle and my top ones are biting down on.
Yeah, you've got a cross bite.
Yeah, and that came with the being out of alignment. And I struggled with that because my when I first noticed it, you know, after having so much surgery on my mouth growing up, and then when I first noticed it after they had taken the wires out of my mouth after breaking it in my car accident, I knew there was something wrong. And my oral surgeon who did repaired my jaw, I don't know if he just didn't want to recognize that that there was a problem or what, but he got really mad at me. And he's like, no, that's the way it was before. That was the way it was before. And I'm thinking to myself, well, how do you know? Because you didn't know me before.
Mm-hmm.
And so the first time I went in, and my dentist at that point, I was in Arizona, and he was a good friend to my family and a good friend to me. And I went in and saw him, and he took the molds of my teeth, and he comes back to me, and and this is about 6 months after I wrecked. And he comes back to me and he says, he said, Mary, I can't fit the molds together. He's like, I can't make your bottom jaw fit on your top jaw.
Mm-hmm.
And my first thought, and realized that I was significantly younger than I am now. But after dealing with a doctor that was really mad at me, and then this dentist telling me, look, they don't fit right. They don't fit together right. And I went, yes, because I knew that I was in the right. I knew that there was something wrong.
Yeah, I'll bet the surgeon just didn't want to have to go back in, because to fix that, you would either have to do orthodontics or have that surgery again.
And there's no way to fix it at this point, because if you do, I'm going to lose the teeth.
Right.
I mean, and I recognize, and I tell my dentist this my dentists that I work with, they know that I'm essentially straightening the chairs on the Titanic right now, and that I get them cleaned and I keep trying to take care of them, but I know that they're falling out. But because they're so involved in your speech pattern, I don't want them. I want to leave them in there as long as I can keep them in there.
Yeah, of course.
Yeah, it's an interesting adventure, but I really, are you working in that field now?
I was in February, and I have braces and I have Invisalign, so I go in and see, my boss all the time, and I go in there a lot, and I'm studying dental right now.
Oh, awesome. Awesome.
I wonder, did you come in to Dietrich and Peterson Orthodontics? Because your teeth look very familiar to me.
I don't even know where that is.
It's in York.
See, I've only been to York one time for my interview with Hack.
Oh, okay.
Yeah, my teeth look very familiar. That's funny. All right.
I recognize people by their teeth.
You would know. So long term, are you looking at dental hygiene, or are you looking to go back into the orthodontics again?
Dental hygiene. I really loved orthodontics, but dental hygiene, like the pay is like 2 or 3 times more.
Oh, really?
Yes. You can get like $58 an hour as a hygienist in Maryland right now.
Wow. Nice. I know it's a lot harder to get benefits for dental hygiene a lot of times.
Yeah, it can be, because a lot of places, they like to just hire part-time hygienists.
Right.
But that's fine for me, because my husband, he's a butcher, and he has him and his dad have their own business. So we get good benefits through that way. So I just am going to be a dental hygienist a few times a week, so that way I can still stay home with my kid.
I understand that. That's awesome. Yeah, you'll be very good at it, Chloe. You do really well in the class.
Thank you.
When you texted me yesterday, I was like, I know who you are.
Oh. One of the troublemakers.
Oh yeah. Yeah, that's really it. But No, I've seen, I can tell a lot of times, I look at the grades pretty regularly, and I can tell where people are fitting in. And so you're doing really well. So you're on a really good route. Are you looking at staying at Hack to do dental hygiene?
Yeah, I think there's only one other school around this area. I don't know what it's called, but the closest one, it's in Harrisburg, Hacks program. So that's around close to an hour from my house. And there's only one other school around me
Do
that's,
you look going into Maryland?
I haven't looked into Maryland.
HCC, I have a former student who's at HCC with dental hygiene, Hagerstown Community College. I don't know what Carroll has, but Carroll isn't that far from York either.
Okay.
And you, with your grade for A&P, and I don't know what your overall GPA is, and then
it's pretty high. I graduated with, I think, a 3.96.
You're highly competitive for that field. So apply into the best program that has the best graduation rates and has the best for getting their students, helping their students if they look for a program that is best for helping you get a job afterwards and helping you get the experience you need to make you easily employable.
Mm-hmm. Yeah, my dentist right now, I told him that I'm going to school for dental hygiene, and he told me, he's like, well, you just let me know as soon as you
You're his.
Graduate, and I'll hire you.
Oh wow!
And I know a lot of dentists in York because the office I used to work at, the orthodontic office, we would put on an annual OSHA meeting, and we would host for, I forget, it was like over 500 people for like all the dentist offices around our area. So a lot of I do know a lot of the dentists in York because they associate me with the orthodontic office that I worked at. So I don't think I should have to worry too much after I graduate.
Then you know what? Stay here. Stay in this area.
Yeah. I think Harrisburg is probably the closest to me. I actually live close to New Oxford.
I know what that is.
Yeah, so Harrisburg I think may be the closest to me.
All right. Yeah, I mean if you already have people who are ready to hire you as soon as you're done, stay here.
Yeah, and I heard I've been told Hack's program, they said that nursing and dental hygiene are the most competitive.
Usually they are the most competitive everywhere.
Yeah, and they only accept 25 applicants total.
Yeah.
For each clinicals. So
I think you're going to be one of their better matches.
Well, thank you. I'm certainly working really hard to try to keep my grades up, and I just have to study for that TEAS test.
Well, I can't imagine them getting a better competitor or better students. So
well, thank you.
You're welcome. Have a wonderful day, okay?
You too.